Welcome to the ultrasound case of the month for October. My name is Greg Zahn. I'm one of the members of the IUEM Ultrasound Division. The September case is still available for viewing as well in case you missed it. If you are new to this series, the case of the month is intended to highlight an interesting case showing how bedside ultrasound can assist in the evaluation and management of our patients. As a reminder to the residents, don't forget to email me at gzahn@iu.edu if you have an interesting case. Each resident featured on the ultrasound case of the month will receive this 26-ounce Yeti water bottle. The recipient of the Yeti for this month is Dr. Carter Dugan, one of our third-year residents and currently one of the chief residents. He was working in the critical care area of the department when medic called ahead with a medical alert patient. The medic report informed the treatment team of a 59-year-old male with acute onset of lower abdominal pain. The medic report was remarkable for what was described as a pulsatile mass near the patient's umbilicus. Upon arrival in the emergency department, the patient was found to be in moderate distress and was intermittently clutching his periumbilical area. Medic had marked an area on his abdomen where they felt the pulsatile mass, and he had a large X drawn on his abdomen just right of the umbilicus. His vital signs were obtained by nursing and were fairly unremarkable except for a heart rate of 115. On physical exam, the pulsatile mass was not very impressive, yet Dr. Dugan astutely grabbed the ultrasound machine and decided to look at the patient's aorta, given his pain complaints and the inability to ignore the large X marked on the patient's abdomen. The following views were obtained by Dr. Dugan. As the label suggests, this is the sagittal or long axis view of the proximal aorta. The pulsatile tubular structure is easily identified here. We advise measuring the short axis depicted here, given the ability to avoid the theoretical cylinder effect that could easily underestimate size if you're not directly in the center of the aorta in a sagittal orientation. Both the AP and lateral diameter measured below the 3 centimeter threshold. Additional views were subsequently obtained at the distal aorta. Like the proximal view, this did not appear to show any aneurysmal dilation. A final picture was obtained of the distal aorta, again not showing evidence of aneurysmal dilation. Given the variable skill level of the viewers, I included an educational handout produced by one of our former residents, Dr. Jacob Capito. These next few slides cover the 5 views the ultrasound division requires for credentialing studies. We want to see 5 views: the proximal, transverse, and sagittal aorta, the distal, which is often described as right above the aortic bifurcation, transverse and sagittal, and then a view through the aortic bifurcation. If needed, please pause the video and take the time to review each of these in more detail. Above 3 centimeters is considered the upper limit of normal. However, the risk of rupture increases dramatically greater than 5 centimeters. This clip displays the aortic bifurcation, which we did not display in the patient's case. Measurements of the iliacs should be less than 1.5 centimeters. Greater than this value would be considered abnormal. While many of you have seen a normal aorta on ultrasound, finding an aneurysm is a little more rare. To help further the educational mission of these cases, I included a few clips from previous cases. Here we can see a large pulsatile structure with an echogenic C within the aorta. The important concept here is the display that we need to make sure we measure the true size of the entire aorta, not just the internal lumen here. So if we were measuring the true size, we'd measure it from here to here and here to here. Here's another clip of an aortic aneurysm displayed in sagittal view. Again, one could easily measure just the lumen here and not the entire structure, and making sure you measure the entire aneurysm from here to here. Here's the same case with a transverse orientation, and we can see that central lumen, but this is the entire aorta and the entire aortic aneurysm. Sorry about the little diversion into abdominal aortic aneurysm ultrasound. Based on the patient's ultrasound imaging, it clearly did not see an aneurysmal dilation of the aorta. While the ultrasound was still at bedside, the decision was made to view the area where the patient was most tender in the area marked with the X. The above clip is what was identified. Even without much ultrasound experience, most people could state they see a large fluid-filled tubular structure with movement of fluid contents within that structure. Another clip shows a more classic view of what can be seen with this specific pathology. What we are viewing is small bowel, and the finding we are witnessing is abnormal peristalsis represented by the back and forth movement of bowel contents. This finding made the treatment team very suspicious for small bowel obstruction. The treatment team noted the abnormal peristalsis, the dilated loops of bowel, and edema outside the loops of bowel, also known as tanga, which we can see here. Additionally, the visualization of the plicae circularis became apparent in small bowel obstruction. This is the finger-like projections that extend into the lumen, also known as the keyboard sign. To help with the diagnosis, the size of the dilated loops were measured and compared to 2.5 centimeters, which is commonly cited as the upper limit of normal. Multiple bowel loops were found to be dilated, and multiple loops showed the abnormal back and forth peristalsis. Given the classic symptoms, there was a clear diagnosis of SBO, yet this patient had no history of previous obstruction or previous surgeries of the abdomen. A CT was ordered with an indication of SBO found on ultrasound to evaluate for potential etiology of the obstruction. The findings that have been published to diagnose small bowel obstruction ultrasound are abnormal peristalsis with that classic back and forth movement. In healthy patients, as we stated, interluminal echogenic content showing move in one direction. Additionally, findings are dilated loops of bowel that are non-compressible above 2.5 centimeters and the plicae circularis, or that keyboard sign that we depicted. In order to obtain the highest sensitivity, make sure to examine all parts of the abdomen. We recommend lawnmowering across the abdomen to make sure the entire abdominal cavity is examined. This means covering the entire abdomen to make sure no areas are missed. The curvilinear probe is often best in its ability to help displace bowel gas. Additionally, a lateral approach on the abdomen can help avoid any anterior located air. When these techniques are utilized, the evidence displays an impressive test performance, meaning that a meta-analysis of nearly 1,200 patients in 11 different studies showed a sensitivity of 92.4% and a specificity of 96.6%. When comparing ultrasound performance to plain radiographs, you can easily see how ultrasound surpasses and outperforms plain radiographs for the diagnosis of small bowel obstruction. To wrap up our case, the radiologist actually called quite impressed with the indication for the CT scan, especially since the patient had no surgical history and no history of small bowel obstruction. And here's a representative cut of the patient's CT scans. There was no known adhesions, tumor, or any other type of cause for his obstruction. He was admitted to the surgical team, and just with conservative management, he started having return of bowel function and was subsequently discharged home on hospital day 2. The biggest question I receive when discussing non-classic ultrasound applications, which likely include small bowel ultrasound, is how do we use this clinically? My answer in these cases is that we as clinicians want more information in order to make the best decisions regarding testing, treatment, and disposition. I think ultrasound provides more information that we can utilize at bedside within that existing framework. As displayed in this case, advanced imaging was obtained given no history to suggest a cause, and this being the patient's first presentation. While ultrasound may be able to diagnose an obstruction, it cannot often tell the reason why or if this is potentially a higher risk presentation, such as a closed-loop bowel obstruction. Additionally, there are the possibility of potential false positives, including ileus and gastroenteritis. As with all imaging, make sure the images obtained match the clinical picture. Well, thanks for watching, and I hope you enjoyed the case. And don't forget to send me any interesting cases to the email at gzon@iu.edu.